Hello, and welcome to the Better Man Clinics, the podcast where we talk to actual experts to address the questions that men want answered, but are either too embarrassed to ask or simply don't know who to ask. Before we get started, I do want to caution that the conversations on this podcast are for informational purposes only. They don't represent a medical consultation, nor do they present medical advice to individuals. Rather, we hope that the podcast empowers men with the knowledge and confidence to address these issues with their healthcare providers. As with any medical or wellness issues, you should always consult with your healthcare provider before beginning any type of treatment or preventative intervention. Now, with that being said, in this episode, we discuss genomic testing for prostate cancer. Now, historically, decision-making for the treatment of prostate cancer has been guided by factors such as an abnormality felt by a physician during a prostate exam, the level of the PSA blood test, and the microscopic appearance of cells that are obtained from a prostate biopsy. More recently, however, DNA testing has started to play a larger and larger role. Genetic material obtained from blood, urine, and the prostate itself is being analyzed via genetic and genomic testing to help determine whether someone may or may not have significant prostate cancer and whether they need further biopsies and treatment. But how are these tests actually performed? What is the difference between genetic and genomic testing? How reliable are they? And how much value do they actually bring to the decision-making process surrounding the treatment of prostate cancer? To answer these questions and many more, we turn to a true expert. Dr. Jeffrey Tosoian is an assistant professor of urology at Vanderbilt University. He earned his medical degree and Master's of Public Health in epidemiological and biostatistical methods for clinical research at Johns Hopkins. He completed his residency training in urology at the Johns Hopkins Brady Urological Institute, and then completed a fellowship in urologic oncology at the University of Michigan. His research actually focuses on the development and use of diagnostic and prognostic tools, including blood, urine, and tissue-based biomarkers to guide the diagnosis and management of prostate, kidney, and other genitourinary cancers. He has authored more than 100 publications in high-impact journals, including the Journal of the American Medical Association, JAMA Oncology, and the Journal of Clinical Oncology. And now, without further ado, I bring you our conversation with Dr. Jeffrey Tosoian about genomic testing for prostate cancer. Hello, and welcome to Better Man Clinics. Today, we're going to be talking about genomic testing for prostate cancer. Now, historically, decisions about prostate cancer have really been judged on three criteria: what a prostate might feel like on an exam, what the ubiquitous PSA blood test might show, and what the prostate cancer cells actually look like under the microscope. But recently, a number of DNA-based genomic and genetic tests have come out that are supposed to really help streamline the decision-making process for prostate cancer, making that decision much more specific to individual patients and their genetic breakdown. But do these tests benefit all men or men in specific situations? For instance, can genomic testing help us identify men at higher risk for prostate cancer who may need a biopsy more than others? Can it help determine for those men who have known prostate cancer, which men actually need treatment versus those who can just be observed? And for men with high risk prostate cancer, can these tests help determine what their prognosis is and whether they need additional or adjuvant treatments on top of the mainstream treatments available for prostate cancer? Now, to help us answer these questions and many more, we're grateful to be joined by a true expert. Dr. Jeffrey Tosoian is a assistant professor of urology at Vanderbilt University, and he is an actual expert on genomic testing for prostate cancer. Dr. Tosoian, welcome to the program.
Thank you. Thanks so much for having me.
It's our pleasure. And I know there are a lot of guys out there that are wondering whether genomic testing is right for them. So it's a very timely topic. Before we dive into that, though, what I'd love to know is, and I'm sure our viewers and listeners would as well, just to learn a little bit more about you, specifically, what drove you to follow a career in in urology, and specific in cancer-based urology, and even more specifically in treating men with prostate cancer.
Sure, of course. Strangely enough, as a kid, I had decided I either wanted to be a professional hockey player or a cancer doctor.
Makes sense.
Right. And we'll say when the one was clearly going to fall short. No, it's I always had an interest in cancer, strangely, from like as early as third or fourth grade. I remember learning about an oncologist and deciding, that would be something worth pursuing. And so I had always really thought I would pursue either medical or pediatric oncology. And it wasn't until medical school and started, going on rotations and saying, I like the idea of being able to remove cancer, and started exploring the different surgical fields. As I guess we could say added motivation. I did growing up, my parents, between the two of them, actually had 3 primary cancers diagnosed.
Oh, wow.
And so it was a big part of my life growing up and kind of being on the patient side of things. And I think that's something that never really leaves you. And so I do my best to always put things in terms that make sense to patients, and try not to be overwhelming with the information, because it's very easy to be.
For sure. And especially with topics like cancer, and especially now with like the topic that we're discussing, which is genomic testing, where people, when you start talking about DNA and genetic based tests, people get overwhelmed very quickly. And there's so much word salad out there and acronyms and whatnot that it can be very intimidating very quickly. And that's why really one of my goals for this particular episode is really to get down to the basics and really get an understanding of what all this means, and really get around the naming conventions here, so people really understand kind of what's involved. So to dive right in, we're going to start with the most basic thing at all. What is genomic testing exactly?
Sure. So, right. And already we're at a place where this can already get confusing, and need to really try to simplify things, even in the words themselves. So when we talk about genomic testing, that's really talking about, so each person has our own unique genetic code, which comes in the form of DNA. The long string of structures, as you know, called nucleotides, and each of them carry a label in form of one of 4 tags, if you will: A, T, C, and G. And so if we zoom all the way into our genetic code, we're really looking at just a sequence of these 4 letters, and how those letters differ in their order and arrangement is what makes each unique individual's genetic code. And so all of us have about 25,000 different genes, and all of these considered together are called our genome. And so genomic testing, broadly speaking, is the study of looking into the sequence of those DNA units across our genes. And where it gets tricky is, and we had talked about this, the difference between genetic and genomic testing. If you probably had follow-up questions specific to that, or I can.
So you did a good job in understanding that genomic testing, we're looking at just the DNA makeup of somebody, right? I guess the first question I have with that is, what's when it comes to prostate cancer, there's 2 things that come up. They come genomic somatic, and the other term is genetic germline. And this can get really confusing for people. What is the difference between the two, or is it the same thing?
No, absolutely. It's a great question and an important distinction to make. And so each of our individual DNA present in the cells throughout all of our bodies that make up who we are carry the same genetic code that's unique to us. And so germline testing is referring to testing those cells, that genetic code. And so that's what tells us about our predispositions. So it can tell us whether we have certain changes to genes that make us more likely to be diagnosed with a certain type of cancer, like prostate cancer, and how our body might respond. So this germline testing it's the genetic code that we've all inherited from our parents. And that's distinct from genomic or somatic testing. I try to use the terms germline and somatic to draw that distinction, just because genetic and genomic sound so similar. And so somatic testing is what's used more when we're talking specifically about cancer, because the cells that make up a tumor have their own genetic code, which again comes in the form of DNA. And in these cases, cancer's DNA has been altered or mutated, is the term you hear often, in some way that will result in this uncontrolled cell growth or cell division that we recognize as cancer. Mm-hmm. And so testing specifically the cancer cells is what we more frequently would call somatic testing or tumor testing. Mm-hmm. And depending on the exact scenario, there could be a reason it would be useful to test only one or both of germline versus somatic DNA, because they tell us different things for a large part. As we had mentioned, germline testing will tell us more about specific genes that we inherited from our parents, that we've harbored since birth, that could put us at increased risk for a given cancer. Examples of that would be the BRCA genes, BRCA for breast cancer, though those are now also known to be associated with increased risk of prostate cancer. Mm-hmm. Somatic testing, on the other hand, looks to see what exactly went wrong in those cells that have become cancer cells. And in some cases, we will have specific treatments that are targeted to addressing those specific defects. Mm-hmm. And so, that's this new era of tailored therapy, personalized medicine, particularly within oncology, is the hope that we can identify specifically what went wrong with a tumor, with the cells in that tumor, and having a treatment that specifically addresses that abnormality. And there are a handful of instances where we are able to do that.
No, that's actually a great explanation. So it sounds like for genetic germline testing, that's a test of what could be, meaning what you might be at risk for, what you're prone to, versus the genomic somatic testing. It's actually it's what it is, right? You already have something, and what the genomic somatic testing is will tell you what you should do with that then, based to really make it more precise and streamlined to your specific tumor rather than the generic prostate cancer, for instance. Is that correct?
That's exactly right. Exactly right. And our germline genetic tests are more, they do have some role at that later stage in specifying treatment. They're largely, for understanding the risk that oneself and, many people bring up, well, I have two sons. We want to know, what their risk is. And so in terms of understanding the level of risk of a family throughout their lifetimes is what we're talking about in germline testing.
And with that actually helps a lot to differentiate the two. And with that difference, I'm assuming then how those tests perform would be different, right? I mean, I would assume that whatever you're sampling for genomic, which it sounds like based on what you're saying is the actual tumor or at least the prostate, right, is different from germline genetic testing where you probably don't need that tissue, right? You can get it from somewhere else. Is that correct?
Exactly. Yes. Germline testing is traditionally performed with either a simple blood test or, a saliva sample or swab. Because, again, these germline DNA is present in all of our cells. And so, taking those cells from any easily obtained source works. And right, the somatic or tumor testing, will generally require a biopsy
Of some sort.
tissue
Yeah.
sample. Yes.
No, that helps quite a bit. So now that we've got that nomenclature down, we understand what's what. A way I'd like to proceed is, which I think will be helpful to a lot of the guys, is to actually do a few scenarios, so that rather than just going test by test, which I don't know how exciting that's going to be for people. I think people want to understand, okay, in this scenario, can I benefit from this, right? So let's start with a simple one. You take the general population of men, right, who are in the range for being screened for prostate cancer. Now, we have the ubiquitous PSA test, a lot of baggage, a lot of controversy, but still an important test that's used. Notwithstanding the PSA test, can we utilize genomic or genetic testing to identify a category of people, a subset of people at higher risk of getting prostate cancer from the general population?
Absolutely. And so where that has become, very important is, as you referred to, right? PSA has become ubiquitous everywhere in terms of a first line screening test. It's easy. It can be measured in the blood. Unfortunately, PSA, or prostate specific antigen, as the name implies, is a marker of prostate cells, which is a start, but it's not a marker of prostate cancer. And so prostate cancer is, one of several reasons that PSA can be elevated. And so acknowledging that not every man with an elevated PSA has prostate cancer. In fact, it's less than half that will. There are now strategies to say, okay, if we biopsy every man with a PSA greater than 3, we're going to be doing far too many biopsies. The majority of those come back negative, or find the low risk prostate cancers that we simply monitor now on active surveillance. And so an area of great importance is among these men better stratifying who is really at higher risk, and who stands most likely to benefit from a biopsy. And so our two main tools for that are imaging with MRI and a number of biomarker tests, which strictly speaking would probably not be considered a genetic test or genomic test, but they are ultimately measuring the results, the intermediate or end products of that genetic code, and those products do inform as to the risk of cancer. And so there are currently 6 of those, 3 in blood, 3 in urine, that can be used at that stage to better define who will or will not benefit from undergoing a biopsy.
And so, not to dive too far into that, but can you tell us a few of the names of those tests, just so that the guys are more familiar with that, so they can kind of categorize, okay, where do those tests go, basically?
Absolutely, absolutely. And, with to varying extents, with varying degrees of good clinical data supporting it, supporting their use. They really all, the six together have been shown to improve risk stratification. And the level of evidence does vary, however, and certainly the access to them at various clinics, given none are a standardized part yet of our guidelines, but rather they're suggested. So I often tell folks that they all do a pretty good job, and it might just be a matter of which is available through your urologist or your provider. And so the blood tests are the 4K score, which is one that provides a continuous risk assessment, meaning a continuous level of risk. You'll get a percentage, 5%, 10%, 20% of, if a biopsy were performed, of the likelihood of detecting clinically significant, higher grade prostate cancers. And so that measures PSA and 3 associated markers found in the blood, to predict that, along with some clinical factors such as whether the patient had a previous negative biopsy, a family history, the results of a digital rectal exam. And the 4K score really, I think it's fair to say, has the largest body of evidence, for its use. It's been, very well validated and calibrated, and is pretty widely available. And so that's one that many folks may have heard of. The other blood tests, there is the Prostate Health Index, which is sometimes abbreviated as PHI or PHI, which similarly measures 3 markers in the blood, which are plugged into a mathematical formula that gives us a number, a continuous number ranging from 0 upwards, that represents the likelihood of detecting cancer. Mm-hmm. And so that is also available and uses the free PSA test, which some patients may be familiar with. That was kind of the first of these tests, back in the 90s, to say, okay, maybe we can do better than just PSA. Mm-hmm. And so PHI, or the Prostate Health Index, is one of those. And then the third is still very new. It's called ISO-PSA, and it was initially available only there at the Cleveland Clinic, where a lot of the early research was done, though I believe that is now expanding, to the point that it is now mentioned among the others as one of the available tests for this purpose. And that is unique in that, rather than measuring a concentration of the abundance, the amount of certain markers, it looks at the various forms of PSA and the ratio of how PSA presents in the blood, to again attempt to better quantify the risk of having higher grade cancer.
Got it. So that helps to kind of delineate. And as you mentioned, these aren't pure genomic tests, not pure DNA testing, but they still do help. There's still markers that help. But here's a tough question. Well, 2 questions. One question is, can any of these tests definitively rule out the need for a biopsy?
Just about.
Okay.
And
Fair enough.
Yeah, no, and we'll talk in a little more detail here. So, in addition to those 3 blood tests, there are the three urine-based tests. There is Select MDX, which is a test that measures RNA, mRNA in the urine, of 2 biomarkers to, again, attempt to quantify this risk of, the type of prostate cancer that we care about, the type that we need to treat. Another is called the ExoDx Prostate IntelliScore, which similarly, is urine-based, measures RNA present in urinary exosomes, and results in an individualized risk score based on the level, the abundance of those markers. And then there's the My Prostate Score, or MPS test, which is the one I'm probably most familiar with, because I spent several of the last of my recent years leading some of that research, that is based on the PCA3 marker, which in and of itself was FDA approved in the repeat biopsy setting. And then a more novel marker that was discovered and described in the lab of one of my mentors at the University of Michigan, Arul Chanayan. And so combining those 2 urine-based markers, and I'm sorry, that marker is actually a fusion of 2 genes. It's the TMPRSS2 gene and ERG. And so using those 2 urinary markers combined with serum PSA, with the blood PSA, that test similarly results in a number from 0 to 100, estimating the risk likelihood. And so whether or not these tests can definitively rule out is a tricky question, because there's always some level of error there. And so, for example, that also has a lot to do with how the studies are performed. And so, for example, for the MPS test, I was fortunate enough to lead some of the clinical validation studies we published in the last couple of years. And after talking to, a lot of colleagues, a lot of patients, I found that, I think that is what we really wanted, what we really needed, right? Nobody wants to undergo a prostate biopsy, but patients understand that if you got to do it, you got to do it. And so it was really finding those tests that, could strongly rule out the likelihood. And so we had set that in our studies. We had aimed for at least 95% or higher certainty, if you will, in ruling out the diagnosis. And what we found was that using a threshold of 10 on this scale of 0 to 100, patients with a score of 10 or less actually had a 98% negative predictive value for not having significant prostate cancer, which is pretty darn close.
It is.
Certainly enough to help us sleep well at night.
Yeah, and while that test can't tell a patient you don't have prostate cancer, don't worry about it, 98% is pretty good. It's not bad for government work. You know what I mean? Right. That can definitely do a good number there. But I'm going to put you on the spot. So you said you're coming from the University of Michigan, right? So not too long ago, we had the chairman of University of Michigan, Dr. Palapatu, on, and I put him on the spot too. And I asked him, should all men who are with an elevated PSA who are considering prostate biopsy get an MRI? And he said yes. He said yes because of, if it's negative, it's going to really help, assuage concerns. And if it's positive, it'll help us target the biopsy, if nothing else. So he said yes. Now, obviously, there's financial issues, not his financial issues. I'm talking for the patient in terms of costs and stuff. Same question to you. Should all men get these biomarkers, all men with elevated PSA, I should say, get these biomarkers before getting a biopsy? Or is it specific subsets that this is more intended for?
Absolutely. And right, this is why our guidelines now will, frequently bring up shared decision making, because these things, in addition to, understanding what a risk is or quantifying what someone's risk is, those numbers, that risk means something different to different people, right? A 5% risk of having a cancer that we need to treat, a significant prostate cancer, for a lot of men is low enough that we say, let's forget about looking into it further right now. We can recheck PSA in 6 months or a year, and kind of sit down and assess again. Though there are some men who 5% is enough to keep you up at night. And that's where some of this balance comes in. That's why we validated the MPS test to have such a very high negative predictive value. On the contrary, a test that's also very well validated and calibrated is the 4K score, which, rather than having a kind of threshold for negative like that, they present each patient with exactly what the test estimates their level of risk to be. And so some patients may get a result of 4%, some may get a result of 10 or 15%, which is kind of our gray area there. And some will be 20% or higher, where almost all patients and physicians will say we need to pursue a biopsy when the risk is that high. And so, should all men get a biomarker test? I think all men at this point should get either a biomarker or an MRI. And so, yeah, that's a conversation that Dr. Palpatu and I have had many times. And I was going to say, I can tell you what his answer is. I know that it's yes. And to that, I would, I say, I tend to agree that at the University of Michigan, or here at Vanderbilt, or at Hopkins, where I did most of my training, MRI is reliable enough and reproducible enough that I think it is a great option. The problem with MRI is that it, of course, depends on the radiologist interpreting that MRI. And we know that there's great variation in how the MRIs are read at our, expert centers, if you will, our large academic centers, versus in the community, where the majority of patients see their doctor at, private community practices.
Right.
And, not only do we know that it varies in terms of how each radiologist will rank the prostate as they see it. So we use, as you know, a scale of 1 to 5 called the Pyrad Scale, where 5 means there's a very high likelihood, usually upwards of 80%, of detecting significant cancer, and 1 and 2 are down less than 10%. And so not only is there a difference in what each radiologist calls what they see, but also in the likelihood that Dr. X's Pyrad's 5 is equal to Dr. Y's Pyrad's 5 varies. And we know that even within the expert centers, from person to person, that varies, though it's less discrepant. And so that's the pause with MRI right now. is that, not all MRIs are created equally.
Right.
And certainly having access to MRI, in some cases, particularly in the United States, the cost associated with MRI can be prohibitive. And then, of course, we have patients with certain types of implants or even with claustrophobia that can't undergo an MRI. And so I think we're at a place where it would be great for most patients in the PSA gray zone, and that's an important distinction to make. And that's that patients with a PSA greater than 10, you could argue that MRI should be performed to potentially identify lesions that would be targeted at the time of biopsy.
Hmm.
But, all of those men have sufficient risk that biopsy is the right thing.
Right.
And so it's in that PSA of 3 to 10 that I think, it would be nice to be able to offer all patients either MRI or biomarkers to better understand, where their risk stands, so that we're not, going back to the old days where every one of those patients undergoes biopsy and, upwards of 70% of them are negative.
Right. And in that same respect, with the biomarkers are standardized, so there is none of that kind of subjective factor in play. Is that correct?
That's correct, right? At the end of the day, it's an objective measurement, right? There's no art to it. There's no personal perception. They're
Right.
all standardized, and so my perfect world, what I think I'd love to see us get to is that we have these biomarker tests which can be obtained right very easily right in our clinics, and so and in many cases, though again in the United States, cost is something that's very difficult to measure, because there's the difference between cost and charge and what's
Right.
actually paid. But certainly the cost of running the tests, for the most part, is substantially lower than the cost and time and expertise required for an MRI. And so, my perfect world, I think we would be sitting down in clinic with a patient who has an elevated PSA in that 3 to 10 range, and we're able to offer, a biomarker test
Mhm.
that we can use the urine sample they've already given, or a blood test that they're going to get anyway on their way out. Get that additional information, and then the patients who can't be confidently ruled out or ruled into a low risk category based on that test, I'd love to see then go forth with MRI, and biopsy, because MRI does improve the yield of our biopsies, in that
Right.
it gives us targets that we can aim for at the time of biopsy, which have been well demonstrated to increase the detection of higher grade cancers.
It makes sense. So let's say we went through this exercise and you know what? We feel there's enough risk. We went ahead and underwent a biopsy. Biopsy is negative. We're all happy, but obviously we don't let it go. We're going to keep an eye on things. And, as we keep an eye on things, the PSA starts going up and we're starting to scratch our heads a little bit saying, did we miss something? Why is the PSA still going up? Is there a risk of prostate cancer? That's a common scenario that a lot of men face with their urologists, right? Where we start thinking about what do we do another biopsy? Do we do an MRI? Does genomic testing play a role here in helping us guide that decision of whether a subsequent biopsy or an MRI is needed from the genomic tissue itself?
Yeah. So the short answer is yes, or there are tests available for that purpose. To the same conversation we were just having, the non-invasive biomarkers, so those that do not require tissue, those that use blood or urine, the 6 that we just talked about, do have a role in this setting if it hadn't been used initially. These tests, and again, to varying extents, have also been validated in this tricky population, right? These men that came in with an elevated PSA, had a biopsy because of an elevated PSA. That biopsy was negative, and now, right, we still have an elevated PSA, or we have an increase in PSA, which of course increases our concern. You know,
Right.
the question is, how much can we take from PSA when it was what was used to bring you in the first place for that first biopsy? You know, and watching the trends in PSA, PSA kinetics, that's often called as a generic term, you know, is very common, but hasn't panned out to be as informative as we would hope. And so in this setting that you're talking about, where we already have tissue available,
Right.
there's one specific test in the setting of a previous negative biopsy, and that's called Confirm MDX. And that's a tissue-based test that looks for a specific alteration to various genes called hypermethylation that are known to be associated with cancer. And so this test almost works by capturing sort of a halo effect or a field effect, which is the idea that even if the specific sample one looked at under the microscope from the biopsy, you know, shows no cancer, if there's a cancer nearby, it has been shown that the changes of these genes will occur in the nearby negative tissue. And so that can be measured through the Confirm MDX test, and can even help, because we know where we took each sample from. If you test each of the negative samples, it can say, you know, there was some trouble there on the left side at the base of the prostate. It wasn't cancer, but you know, it has a high % risk on this test. And so one could, you know, at a repeat biopsy, take additional samples from that region.
So a couple of follow-up questions. I just want to clarify. You don't need any additional tissue. In other words, to run this test, you don't need another biopsy to get more tissue. You could use the old biopsy, correct?
Correct. And that's a very important clarifying question.
Especially if you're getting the biopsy. That's for darn sure. Number two, like the other tests, like the biomarkers, Confirm MDX, is it binary? Is it meaning yes or no, there's probably prostate cancer, or is it also like a spectrum where they give you a percentage risk of prostate cancer on a repeat biopsy?
Right. So that the Confirm MDX test gives a probability of high grade cancer, also of low grade cancer, but we found that, right, to be less clinically meaningful, given what we know about low grade cancer. So yes, that report comes with kind of a bar that, you know, is filled up to a certain percentage associated with the likelihood of finding higher grade cancer if a repeat biopsy were to be performed.
Got it. So not to be left out, MRI is going to stick its head in this conversation too. So, you know, one common thing that urologists do when they're faced with a scenario of a rising PSA after a negative biopsy, they get an MRI. And they say, did I miss anything? Especially if they didn't get an MRI before the first biopsy, right? Now, let's say you didn't go that route. You went this Confirm MDX route, and you have two scenarios. One scenario is it looks totally negative. Would you do an MRI just in case? Flip side, it's super positive and it's saying there's a super high risk of cancer in area A and B. It even tells you where to look, right? Would you do an MRI in that scenario?
Yeah, no, it's a great question. So if it's negative, the confirm MDX is negative, then you kind of sit back down and say, okay, what has happened since that biopsy? Again, we tend to look at how the PSA has changed. If that's taken a steep increase, negative confirm MDX may still have these other tests on the table, right, to consider after. It's if cost were no issue, right, you'd say would love to do any test possible to avoid a biopsy. I would tend to say that with a negative biomarker, and this can vary among the biomarkers. So, it's important to review with your doctor and, their understanding of the literature. But most of the biomarkers actually have a better negative predictive value, a better ability to rule out than MRI does. And so in a lot of cases, a negative biomarker would be reassuring that we do not need to then do an MRI. If the plan is also to not proceed with a biopsy, under the thought that the test is reassuring.
Right. And on the flip side, if it does look very positive, and again, as you mentioned, the MDX will tell you, okay, you did biopsies in these 6 locations, and only these 2 are concerning. So it kind of gives you a poor man's MRI, right? It tells you, hey, shoot for there again. But
Yes.
would most urologists say, you know what, if it's positive, I'm still going to get an MRI to help me target, as you said, better target those areas anyway?
Yeah. So I think in a world where, there is no cost, there is no, 6-week wait list for a prostate MRI.
Of course.
Sure, right? We'd love to get all the information we can. Though I agree with you, right? The confirm test does give some of that same information in terms of localizing where the higher risk region is. And so, I wouldn't think you necessarily need to also proceed with an MRI. But as you know, and conveying this to our listeners,
Sure.
this is such a nuanced area in that, right? It can also, one thing that will impact the answer to these questions is how the biopsy was performed. Was it a transrectal biopsy or a transperineal biopsy? Why does that matter? That's because, as the transrectal approach, the samples are generally more from the posterior region of the prostate, the back of it, which is fine and good in most cases, right? Because most prostate cancers will be found in the kind of posterior peripheral zones. But the cases that, we looked back on in our Hopkins data of active surveillance and various, practices such as that, we found that it was those men who we thought had low-grade cancer, or we thought had no cancer at all, who then return and are found to have a more aggressive cancer. Many of those were found to be in the anterior of the prostate. And so, it can impact the risk assessment and how much one thinks an MRI would inform the next step.
So just to clarify that, so the halo effect that you were talking about at MDX, meaning that it'll tell you the risk of missed cancer in that general area, that halo wouldn't necessarily extend all the way to the front or the anterior part of the prostate, potentially, that an MRI could catch.
Potentially. Absolutely.
So
now, on the flip side,
sorry, go ahead.
of course, I'm sorry. On the flip side, of course, we know now that there are high-grade prostate tumors that will be missed by MRI. And that's the concern there, is that, the data have looked at many of these large expert centers, and by and large, the rule out ability, the negative predictive value, is on the level of 90 to 91%, combining these data, the pooled data from expert centers. The concerning part is that, some of those centers, it was as low as, in the 60s. And the authors of the particular review I'm referencing, published in European Urology a year or two back, had intended to make that important comparison of our academic expert centers versus, most community clinics. And they actually found that there are such little published data from non-academic centers that they were unable to carry out that analysis. We don't know enough about how predictive MRI is at those centers that they actually weren't able to even make that comparison. And so, right, all of these tests, we don't yet have the magic silver bullet, if you will, for diagnosis, but we have a lot of tools that certainly improve a heck of a lot upon PSA, though we're still identifying when and how to best use each of those, either alone or in combination.
Well, I think what this discussion shows is truly how nuanced the treatment of prostate cancer is, right? It's not black or white issue. And speaking of that, let's go to the next scenario, which is also not, well, some people think it's a black and white issue. So you have a scenario of, okay, now you did the biopsy. Maybe it was the first, maybe it was the second, maybe it was the third, but it's positive. Okay. But it's not slam dunk positive. It's kind of what we call low risk prostate cancer. And so back in when the dinosaurs roamed, when I was in training, we would take out everything. Everything would be treated for prostate cancer. It doesn't happen anymore, right? A lot of people with low risk disease go into active surveillance, meaning we keep an eye on it. Now, for a lot of guys, that does not make them feel warm and fuzzy, that you're telling me I have prostate cancer, but you're telling me not to treat it. I'm not feeling great about that, right? So can genomic testing play a role here to either go one way or another? If somebody, obviously this is not for high risk disease to say, hey, you have really high risk disease, but you shouldn't get treated. But as a man is diagnosed with, let's say, low risk or intermediate risk disease, more so low risk, and there's a question of, should I just watch this or should I get treated? How or does genomic testing play a role here?
Yes, so great question, and giving a little bit of context to the listeners, as you had mentioned, our low grade prostate cancers, and again, anytime I'm talking to a patient about biopsy results, I make sure that we have at least a half hour. And, usually I've also gone over these things at the time of the biopsy, and because I always joke, right, you could do a PhD thesis on just the language and the various ways to interpret this. And so grade, kind of starting at the very top, grade, as you know, and as will help the listeners, is all cancers are given a grade, and grade is based on the appearance of the cells under the microscope, when the pathologist looks under the microscope. And why does grade matter is because low grade cancers, generally speaking, are less aggressive. And so in terms of prostate cancer, as if things weren't confusing enough, we now have two different scales for measuring prostate cancer grade. There's the Gleason score, which went from 6 to 10, with 6 being truly the lowest grade, which is of course not intuitive. And it's part of the reason why we have a newer system called the grade group, which goes from 1 to 5. And so when we talk about low grade, as you know, we're talking about either Gleason score 6 or grade group 1. And those are the same thing, just different names of the exact same thing. And so low grade cancer, in the vast majority of cases, I actually, and I think the guidelines reflect this, don't see a great role for biomarkers or a great need for genomic testing, with some caveats. And that's because we know now, many years of data, that if we're truly talking about low grade prostate cancer, on active surveillance, the long-term risk of harm, and when I say harm, I mean the cancer spreading, metastasizing, or potentially leading to death, appears to be less than 1%. And so, a lot of this is based on some of the initial data from Hopkins, where my mentor Bal Carter, who's sitting there behind us in that photo, and one of his colleagues and contemporaries, Dr. Laurie Klotz at the University of Toronto, actually simultaneously both started an active surveillance program back in 1995, after realizing, we're not seeing a lot of men with Gleason score 6 cancer who had it treated, who had their prostate removed, ever come back with a recurrence. And so kind of that as our underlying context, our guidelines today say that low grade prostate cancer has 3 treatment options, or 3 management options, which are active surveillance, surgery, and radiation, and that active surveillance is preferred. And I think, most agree strongly with that. There are some caveats, right? These studies did not include patients where 12 out of 12 of the biopsy cores were positive for Gleason score 6 grade group 1 cancer, right? So, high volume. If we could be certain that there only is that low risk disease, then, perhaps, and, I do know some clinicians who say they will not actively treat anyone with, only Gleason score 6 grade group 1 cancer. But it's not unreasonable to have the discussion of the treatment options, particularly if we're talking about high risk, high volume low grade cancer. So a lot of it, or if there's a PSA that's up above 20, which is really discordant, which doesn't match with what we found on the biopsy. You can have that conversation about treatment, though I still tend to I tell our trainees here, in most cases, if a patient who has low risk prostate cancer insists on treatment, we may not, that might mean that we didn't do a good enough job having that conversation, right? Educating them and counseling them on that, letting them know that one thing I bring up that a lot of patients find reassuring is that now, as you know, at our, AUA, our big, academic conferences, or GU ASCO, and in our clinical research, the conversation is, should we even be calling these low-grade prostate cancers cancer anymore?
Right.
Because it meets all the criteria from looking at the cells under the microscope of what would be called cancer. It does not behave in the way that cancers traditionally do, in that these low-grade cancers, within prostate cancer specifically, do not appear to have the potential for spread, which is where harm comes from. And so, with, appropriate confirmatory biopsy, meaning a second biopsy within 1 to 2 years of the diagnostic biopsy that can confirm low-grade prostate cancer, tend to think most men, are well suited for active surveillance and will do very well on active surveillance. It's in that next risk group, kind of the favorable intermediate patients, favorable intermediate risk, where I think there is more of a role for some of these the tissue-based tests to say, okay, we know there's a cancer that at least has some potential to cause harm. Let's look beyond what you see under the microscope, and let's look at the expression of various markers to say, okay, does this appear to be one that we need to treat, or is it a favorable intermediate risk cancer that's truly favorable, and we can consider also keeping an eye on that.
Got it. So can you tell us about some of those type of genomic tests that might be useful in that situation? And just again, I want to be crystal clear. You're talking about scenarios where it's still Gleason 6, but it's a lot of it, or you're talking about Gleason 6 and the PSA is a bit higher than you're kind of like maybe above 10. That's one of those groups. And then one other that I want to just double check, which I know might be a little controversial. What if people have Gleason 3+4 disease equals 7? Is that another one of those that would fall into this category? Or are those because it's a 7, it's just treat?
No, you're correct in that, and this is of course not I'm not only sharing my opinion, but this is right as reflected in our National Comprehensive Cancer Network and AUA guidelines. Gleason score 3+4 equals 7, also known as grade 2 cancer. If that is the only alarming feature, or intermediate or higher risk feature, that is very much in the favorable intermediate risk conversation. That is in that grouping. And so, personally, I would be hard pressed to think I'm doing the best thing for a patient with true, Gleason score 6, low grade prostate cancer. In most cases, even if the PSA is discordant, if it is higher, you lean toward potentially repeating a biopsy, because in the absence of tissue showing higher grade cancer, I find it hard to convince myself that we should be pursuing active treatment, that's what's going to be best for the patient sitting across from me. Though there's certainly gray area there. But particularly these patients that have the Gleason score 3+4 and their PSA is 10 or below, because it being above 10 is another intermediate risk factor, and one of the part of the definition of favorable intermediate risk is that patients only meet one of the intermediate risk criteria. And so 3+4 with a limited volume of that 4, right? So the pathologists will say, Gleason score 3+4, 10% of it showed the pattern 4. And so if it's ideally 5%, or in some cases, other numbers, but below 20, generally speaking, these patients are considered favorable intermediate, and these are the patients who could benefit from some molecular testing to inform. And so again, those are, thankfully, right, you don't have to undergo another biopsy, but it's using the biopsy tissue that has already been obtained. There are a few tests in that space. One is called the Decipher Score, which categorizes patients again in a low versus intermediate versus high genomic risk. Right, we already know their clinical risk level based on Gleason score and PSA and clinical exam, and so this is an independent additional piece of information that can guide us toward what appears to be best for that patient. There's the Prolaris test, the Prolaris CCP score, cell cycle proliferation score, which is another tissue-based test that gives a score on kind of a funny scale in the range of -3 to 3. But again, with the higher score being higher genomic risk or molecular risk. And the third is the Oncotype DX test, Oncotype DX prostate. Some patients from friends or family members are familiar with the Oncotype DX breast cancer test, which really is a well-validated part of that treatment pathway. And so the Oncotype DX GPS genomic prostate score test is the third of those, which again, within these patients where we've gotten all the information we can from the biopsy, from their PSA, and now we're looking at some markers of higher grade disease that are not reflected in that. So these tests provide additional information beyond what we already know to help say, okay, this favorable intermediate is closer to low risk, and this favorable intermediate is closer to unfavorable or even high risk, and that can help guide us toward what's best.
So kind of weird question, but so, when we were talking about the other tests, which were, let's say the biopsies negative and the PSA is going up, and it's telling us a percentage of chance that prostate cancer is actually there. These tests are different. We know prostate cancer is there, and it's telling us the percentage risk, right? But risk of what exactly? Is it risk of death? Is it risk of metastasis? Is it risk if you're not going to do something, or is it risk if you're going to do something? What is that risk that we're addressing?
It's a great question. And so, right, the answer is that these tests have all been validated to, in some cases, different endpoints. And so, particularly the Oncotype DX prostate test gives a percentage that if the prostate were removed, what is the likelihood that we would find, adverse pathology or, worrisome findings, which, as you know, are the truly higher grade cancers or evidence of extension, up against the margin or outside the prostate, or invasion into the seminal vesicles. And so that is right. So the Oncotype DX is validated to that adverse pathology endpoint. The Decipher test has a good array of studies, was originally validated to the endpoint of metastasis. And so, which patients would have spread of their disease over the long term. And the Prolaris CCP score was validated for both biochemical recurrence after treatment. So that's patients who are treated, their PSA then came back, or death from prostate cancer. Now there are caveats to all of these studies, right? Which is why these are offered, but not at the point of being mandated as kind of standard of care for patients with X, Y, or Z is to get this test, because none have reached such a high level of evidence that we know it's what's best, best for guiding our next steps. That said, they do appear to offer helpful information, particularly in those patients who are kind of on the borderline of whether or not they need treatment.
So yeah, that was going to be my next question. So it sounds like they're all looking at different endpoints, but there's no head-to-head study to show that, they compared Prolaris with Oncotype DX and they found Oncotype DX was better. I'm just making this up, by the way. It's pure scenario based, but nobody's found that distinction. They're looking at different endpoints, but it's kind of dealer's choice in terms of which one you want to go with.
Correct. And to make it even more of a gray area, some really great work from Simpa Salami and Ganesh Balpatu and Todd Morgan and mentors of mine at Michigan, showed that these tissue-based tests, if you run all three of them, now again, right, always the caveat that these studies weren't done with the commercially available test, but rather, almost a recreation, based on what is known about the tests and our ability to then, measure those same markers, though not using their exact platform. But with that caveat, the study showed that if you, subjected the same sample or the same region to these different tests, you would in some cases get disparate results. To paint a broad brush, let's say it was low risk for one test and high risk for another. And more importantly, and really the bigger concern with the tissue-based tests is that it also, your result appears to be dependent on which tissue sample they tested. And so not yet a perfect science. And you are correct that there have been no true direct head-to-head comparisons. And they are, matched up with, validated with different endpoints. The thought, and certainly a very reasonable one, is that all of those endpoints, right, are generally associated with telling us more aggressive or less aggressive, right? Whether it's metastasis, death, or biochemical recurrence, right? These are all indications of a cancer returning and causing trouble, but certainly they are not the same.
And I mean, it certainly speaks in this indication particularly that these tests are not the solution. They're part of the puzzle. They help you fill out the part of the puzzle, but they're definitely not the binary, well, this is negative, so don't worry about it. You have to really nuance it and as part of the grander picture, by the sound of things.
Exactly. And so that's why, right, they all have different, probably shouldn't use the word indication when we're talking about the NCCN guidelines, because they use the wording of tests that can be considered. And so the Prolaris and Decipher tests are listed as reasonable to consider use in low risk, favorable intermediate risk, unfavorable intermediate risk, and even some high risk patients. And right then we're talking about answering different questions, though, because no high risk patients are going without treatment altogether, but they can inform on whether multimodal treatment is probably in the best interest initially, or whether a single approach to treatment can be used. Oncotype DX test, as of my last check, was approved for only the more favorable of those, so the low risk and the favorable intermediate risk. Though I do know that they've recently published data in the high risk space, so perhaps it's a matter of time until that is offered for consideration in that setting as well.
So yeah, and that actually leads to our last scenario, which is, again, you mentioned Prolaris and Decipher apply to this as well. Now you have, let's say you've undergone a prostatectomy for prostate cancer, and you get the tissue back, and it's, the doctor comes back and says, I don't have great news. It looks very aggressive, maybe even more aggressive than we thought. We think we got all of it, but there's a question, given how aggressive it is, that, if you will, the horse may have been come out of the barn a little bit. And the question really becomes, are you done with your treatment, or should we proactively add additional treatments? Like, for instance, in the context of surgery, whether you should have additional radiation therapy right away or not because of the risk, which is a really hard question to answer. How does genomic testing help in that situation? What answers will it help us to garner?
Yes, no, that's a great question, and you summarized it very well. The two big questions there are, in patients who undergo surgery, right, should we, after the prostate's out, should we be talking about providing radiation therapy, soon thereafter, as you know, called adjuvant radiation therapy. And in patients who are undergoing radiation instead of surgery as their first treatment, these tests could inform, and I've spoken to colleagues who will, in some cases, take it into consideration. Patients undergoing radiation, the length of time for which they should also be on androgen deprivation therapy or hormone therapy, which for unfavorable intermediate risk and higher is part of radiation treatment. That comes along with a course of hormone therapy, which is not, right. Hormone treatment isn't fun, and so those are kind of the two higher risk settings where these tests could be informative. The post-surgery questions. So there's two important points to make regarding that. One is that there are some recent studies, the Radicals and Raves trials, that indicate that adjuvant radiation therapy, so undergoing radiation, within a short period after surgery, does not appear to offer a big advantage over providing radiation therapy in a later setting called salvage, based on a rising PSA. So rather than saying, the prostate pathology was adverse, had some really worrisome features, off to radiation, we now have some good data that say, as long as we're following that PSA closely and initiate radiation therapy treatment if and when the PSA rises,
Right.
those patients appear to do just as well. And so that kind of changes this conversation, right? Because it's far less likely, or if we are following the data, which I hope we all are, fewer patients would be told that they stand to benefit from immediate radiation therapy. That all being said, the one test that I know is mentioned specifically in the NCCN guidelines in this setting is the Decipher test, the Decipher genomic classifier, and the guidelines say that men whose tissue has a genomic classifier or GC score greater than 0.6 should be strongly considered, is the wording, for additional radiation therapy, and the addition of ADT. And so,
And again, the interpretation, same idea: spectrum, range, percentage risk. No easy answer here. Now, one question I have, and I'm not sure if this is a fair question or not, but I think it would be interesting for people to know. Both in your own practice, and obviously you're in the academic setting, and you talk to a lot of other urologic oncologists. We talked about a few scenarios, right? We talked about, do you get a biopsy? What do you do with a rising PSA after a biopsy? Determining whether to do active surveillance or treatment, and in this case, adjuvant therapy or not. Where do you think genomic, which of those four scenarios do you think genomic testing provides the most benefit? Or is there one where you feel it's most beneficial, where, let's say, you utilize it the most, and or your colleagues do, based on talks that you hear?
Yeah, it's a great question. And so to me, and right, there's potentially, in full disclosure, right, there's some potential bias here in that, a lot of the research I've done is focused in the pre-biopsy space, right? Do we need to do a biopsy? And so I, am extremely familiar with the research that exists and the studies, and feel, very comfortable with when and when not these tests could be informative. Though I would think most folks would agree, that most in the field would agree that it's really that initial step, the elevated PSA, between 3 and 10. Do we need to do a biopsy? And the reason for that is it's almost a math one as much as it is a medical one. And it's just that, right, it's the lowest hanging fruit. If we biopsied all of those patients, we know that so many, such a high percentage will have undergone an unnecessary biopsy. And so that's where, I think is kind of the lowest hanging fruit for us to improve upon, kind of the traditional practice, because there's such a large denominator, right? There's such a large population of men that stand to benefit from additional information at that stage, in that pre-biopsy stage.
And that's important to know, just because of the fact that I may be incorrect here, but from my understanding, most of these tests, I'm not talking about the biomarkers, but most of the genomic tests are not covered by insurance, or by most insurances, I should say, with some exceptions. Am I correct in assuming that?
Yes. The reality is that I'm probably not the best, source of, what is and isn't
Covered, sure.
Covered, largely because it's, these things are actively changing, and folks who use a certain test daily, or regularly will, probably better be able to map that out. And that's all, in the context of whether certain tests are available at certain institutions, and things like that. So that is a tough question, but it's fair to say, right, that none have been accepted as an expected part of the workup.
Right.
Right. Our guidelines,
not like a standard of care kind of thing.
Exactly.
Right.
Exactly.
Right.
Tend to use words like, consider using, or, suggest considering, because, and, I think that's very reasonable, from the guideline perspective, because my opinion is that for most of these tests, there's enough evidence that it improves practice, improves what we're doing for a lot of men, but none have the hook, line, and sinker kind of gold standard level of evidence, which would also, beyond kind of the validity data, which is what we've largely talked about, that also, there's questions that the guidelines have to ask on a population level, right? Is it cost effective? Are we, doing the right thing for the healthcare system by using certain tests. And, certainly to my knowledge, none have kind of bridged all those gaps to the point that it's a no-brainer to be using. And so that's why they tend to be considered. Though I do think the place where we're closest to that is in that pre-biopsy setting, just because really, in my opinion, in my understanding of the data, I think most, if not all, of the tests would rule out, right, would help a fair proportion, we're talking 20 to 35% of those patients avoid what would have been an unnecessary biopsy.
You're certainly not insignificant, for sure.
Right. As you said, especially if you're undergoing the biopsy.
That's for sure. Dr. Tosoian, thank you so much. This has been extremely informative. I'm going to leave you with one question completely unrelated to prostate cancer. The title of this podcast is Better Man Clinics. We try to get everyone to be a little bit better and live their best life. What is the key to your success? How do you live your best life?
Oh my goodness.
There's a curveball for you.
That's being, I don't know. We need a higher bar for success, but to this point, honestly, it's just, having the right people looking out for you, right? And this obviously applies in all fields, but I think for me, it's been, particularly important. I was lucky enough that as a first-year med student, I met Dr. Carter, Bal Carter. I met Dr. Walsh, started working with them. And, really, I could list off, so many folks ranging from, the true senior physicians in the field to, those that were junior faculty when I was training, like Ashley Ross, Ted Schaefer, a lot of, good people who have your best interests at heart and are steering you toward, what matters. I know they mentioned the group from Michigan, and now here at Vanderbilt, I'm incredibly lucky to have folks like our chair Dave Penson, Sam Chang, Dan Barocas, Kelvin Moses. I could go on. I could name colleagues in medical oncology, Ben Park, who have just because we all only go through this one time, and so having folks looking out for you who are there, who truly care about what's the next best step for you to I was fortunate enough to, when I was looking for faculty positions, figuring out where I'd be as junior faculty, they would often say, what are you looking for? And I said, honestly, it sounds maybe cliche, but I'm at a point in my life where I just wanted to be able to have as big of a positive impact, against cancer as possible. And had some geographic freedom and things like that. And and so in line with whatever our goals are, one's goals are, having folks who have been through that and are able to point you in the right direction and help you reach those goals is probably the most important thing to me, which I think is a long way of saying, what Dr. Carter always used to say, though I insist in his case wasn't true, is that any of my success is due to those around me. But certainly, right, in any field, but probably particularly in medicine, having the right folks looking out for you is huge.
Great words to live by, for sure. You always want to surround yourself with those that want you to succeed and are rooting for your success, right?
Totally.
Fantastic words to live by. Dr. Tosoian, thank you so much for all of your great insights. I know the guys will find that very valuable. And to all you guys watching and listening out there, remember the mantra of Better Man Clinics: your best life is a journey and not a destination. Use every day to get just a little bit better. We'll see you all next time.